so much for attending the Building Capacity for Patient-Centered Research Conference. My name is Diamond Hale. I am a project manager with the Patients Program. I will briefly go over our housekeeping notes before we begin our session 3 of the conference. We would first like to start by saying thank you to our sponsor, the Agency for Healthcare Research and Quality, ARC. This project was sponsored by a grant from ARC, and the content is solely the responsibility of the authors and does not necessarily represent the official views of the Agency for Healthcare Research and Quality. This conference is being recorded for prosperity. The information from the conference will be posted on the Patients Program Facebook, YouTube, and website. To limit disruptions through the entirety of the conference, all attendees have been muted. There is a question and answer box that you may use during the conference to ask questions to our panelists. Please do ask questions. They have made time embedded in their presentations just to hear from you, and please we do encourage participation. There is not any more breaks after this. We will have our last session and then closing remarks. Our next session, session 3, and our last session, last but not least, is about dissemination and sharing results and best practices. We will begin with a presentation from University of Missouri, and I will hand off the mic now. Thank you so much for attending again.
Hello, I'm David Mehr, a professor emeritus of family and community medicine, and I was the principal investigator of our R24 grant. And with me is Sue Rogers.
I'm Sue Rogers, a retired nurse, but I'm on the patient advisory board as a patient and caregiver. I was the caregiver and advocate for 5 different family members over a period of years. So I've spent a lot of time on the patient side of the equation.
And we're going to talk about our patient advisory group had a review process for proposed projects, and that's what we're going to talk about. We were fortunate in having institutional support and some support from ARC to provide for multiple pilot projects to help develop skills and foster an understanding of patient-centered outcomes research. The academics engaged in a rigorous peer review process to critically review the applications, provide feedback, and help the investigators improve their ideas. Often, in fact, most of the time, we required them to submit responses to the critiques. And one of the components that we had was a required presentation to our patient advisory board.
Okay, the patient advisory board provides a forum for patients and caregivers to review and influence the projects that the researchers are putting together. We discuss the proposed projects and provide feedback from the patient perspective. How to engage patients, suggested incentives for patients, and then help actually design focus group questions to elicit the best information. We also provide suggestions and feedback on handouts, videos, and patient materials. Early on in the process, the presentations were more like a professional slideshow at a conference, which left little time for discussion with the board. And the projects were almost finalized, so suggestions from the patient advisory board were really too late in the process to be helpful. So to get around that, we reviewed things and provided a one-page format sent to the researchers to give them a better idea of how to work with the group. The information requested includes the title of the project or general idea, and then a brief description, such as length of the project, the plan methodology, number of patients that are needed, recruitment method that they're planning, what will patients be required to do, and then how they going to evaluate things. Then there are suggestions of how the board can help them, such as feedback on patient involvement, ideas for recruitment, significance from a patient perspective, review recruitment ideas and materials to see how patients would respond, and some discussion of whether patient participation sounds like it would be onerous or interesting to patients. So the information, we try to get that submitted before the meeting so that the patient advisory board, as well as the researcher, has some information to discuss and understands it better. Then when we get to the meeting, there's just a little short presentation about it, and we can really discuss the questions and the concerns. So there's questions from the advisory board. This leads to a lot of dialogue with the researcher and questions and responses from the researcher. So we're able to actually devise a better plan, and this occurs earlier in their process. So they haven't completely finalized how they're going to do it. And then we invite the researchers to return to the board and tell us about the results of their study.
So some of the people who made applications to our center, and we told them they had to present to the advisory board, initially had quite a bit of skepticism about its value. But in fact, we found that after people presented, there was nearly universally positive reactions. In the presentations to the board led to a number of very positive changes in the proposed studies, including improvements in the study design, who would be included and who would be excluded from the study. The board sometimes raised questions about whether particular kinds of people would be appropriate or needed to be included. Recruitment materials were often improved. Questionnaires were improved. And as I'll share briefly, in one case, we had a video presentation that was improved. Give you some concrete examples. One of the most vehement investigators about not wanting to participate with the board was an investigator who was working with a clinician on a trial of a yoga breathing technique as a non-pharmacological approach to high blood pressure treatment. This particular investigator just didn't see the value, but in fact, when she did her presentation, this led to advice on changing the protocol, how visits would be structured, to creating instead of using the Sanskrit name for the breathing technique, changed it to an English name that was descriptive. And these various changes really enhanced the success of the project. The investigator afterwards was totally sold on the value of presenting to patients. Another study which involved treatment of irritable bowel syndrome. The investigator, who was a nursing school faculty member, presented a recruitment brochure which had a lot of technical language and was not very well formatted. The patient advisory group really helped her redesign the brochure, which again was a major asset for her study. I mentioned previously videos. One investigator who was developing a video to encourage hospice consideration using the model of telenovelas, which are commonly seen in Spanish language television. The board reviewed the draft video and suggested changes in several scenes. suggested more patient-appropriate language, and suggested in some cases that the video associated with staging specific scenes should be changed. All these things helped make the video much more effective. And then finally, as an example, one investigator wanted to create a registry for potential research subjects. And she presented her idea to the board. And one of the things that came out of that session was that the board suggested a better name for the registry, which was Participate in Discovery. So in summary, we had a whole series of presentations by investigators to our advisory board, both before the projects and at the end. This led to improved projects, far greater awareness of the advantages of patient-centered approaches on the part of these investigators pursuing pilot projects, and further developed the board members into excellent reviewers of research ideas. As well, some of the board members became patient co-investigators on research projects, really substantially adding to those projects.
Thank you so much. Again, attendees, please feel free to use the question and answer feature to put any questions that you may have. So the first question we have from Uzma Khan: who are the community members involved in the review?
Sue, do you want to take that?
Yeah, so we have myself, and then a woman who has chronic lymphocytic leukemia, is currently undergoing treatments at MU, a gentleman who's had long-term chronic back pain over years, and another one, and then there are three other people. One is a young man who's had a kidney transplant. His mother is a diabetic. And then two others that I'm going to blank on what their actual diagnoses are. So
one young man has HIV.
Oh, yeah.
And I would say that we recruited these folks with the idea of being either people who'd had experience with chronic disease or were caretakers for people with chronic disease.
Right.
Thank you so much. We have another question. Can you share an example of what specifically you say to skeptical investigators? Has this changed over time besides you having to do so?
Well, we're able to cite examples of important changes made in their projects. We're able to tell them that investigators who've been through the process have universally found it to be helpful. And in terms of while we were funding small projects, we were able to say, you have to do this. Now that the grant is over and we're continuing on our own, we're still making the process available, but it's specifically available now for people who are doing patient-centered outcomes research. I don't know, Sue, if you have anything to add to that.
No, I don't think so. That pretty much covers it.
Perfect, thank you. We have another question from Nicole Brandt. Thank you for sharing your experiences. We are doing this with one of the research networks I am involved with. Do you have any lessons learned that you can share with rating scales for reviews and ways to best orient reviewers?
Are you talking about the patient reviewers or?
Yes.
Well, I'm not sure about rating scales. I don't know, David, if you have any response to that. When we bring somebody new on the board, we just spend some time with them, actually before we bring them on the board, going through what their history is, why would they be interested, and then talking about the purposes of what we're trying to resolve with patient-centered. You know, most people in healthcare feel like they've been patient-centered all their career till you're on the patient side of it and trying to look at it from the patient's perspective and be advocates for yourself or for the patient. I'm not sure about rating scales, though.
We haven't done rating scales. Certainly with the academic peer review, we used a 1 to 5 rating scale similar to what's used by PCORI or NIH. I'm sorry, it's 1 to 9. 1 to 9.
Thank you so much. Our next question from Jennifer Lavoie. Do you have any training for your investigators before they take advantage of the wisdom from the board?
Sue, do you want to address that?
Training for the investigators before they come to the board? Well,
Yes. Do you have any advice that you would give them as a patient perspective?
Well, like David and I think Robin too, meet with them and talk about what they need to do for their projects. And then we send out the information sheet. If somebody wanted to speak with us beforehand, we could certainly do that. I haven't run into that.
But if there were an investigator that approached you as a patient, from the patient perspective, what would you tell someone that's interested in going in front of a board to get reviewed for their project? Like things you would want them to consider.
Okay. I would talk to them about what they're trying to do is understand a different side of the equation, a different perspective. And I might try to use an example of if you're the clerk in a store or the customer, and when you're asking a question, the clerk looks at it one way, the customer looks at it another way. Or if you're dealing with a child, it's like what's your context and worldview versus the person that you're trying to talk with or work with. And then if you point out that if you're trying to do research and ask questions of people, ask their participation, in order to do that successfully, you really need to get a clue to what's their point of view from where they're standing and what context do they already understand or not understand before you can actually come together and be talking about the same things. It would be a dialogue for a while because you'd have to also make sure, like if I'm doing that with somebody, I would be asking some questions to try to understand what their current view is so that we could figure out how far apart are we, what kind of things do we have to discuss to be able to come to a common understanding.
Perfect. Thank you so much.
There's a question in chat about inviting patients who one has had a direct relationship with. And I did invite some patients of mine that I'd had a relationship with. Obviously, some of them agreed and some didn't. It was it's been a positive experience. It's certainly not been a negative experience. I wouldn't hesitate to do that. I suppose there could be some circumstance in which that created a conflict of interest, but you would just need to be conscious of that. I think working with people that you have relationships with is always a great way to get people. I'd add that some of the people we recruited on the board were people that my wife knew that were just ideal. She was a school teacher and had met many people. And so with her help, I approached some people and they became really effective members of the board.
Perfect. Thank you so much. And we're going to have one final question before we move on. From Jennifer Lavoie, how is your advisory board governed? I know this is a big question, but even a few simple examples of how they manage themselves as a group.
Very casually, actually. One of the administrative assistant with David's office does the appointments and sends out the information, sends us information about what the topics will be at the next ones. But then in the meeting, I usually chair that. So start doing the introductions and try to keep the discussion on track. Lynn, who's the assistant that sends out information, also keeps a few notes about the meetings. Other than that, it's not a heavy-duty structure.
David, do you have anything to add before we move on?
I saw that the clarification of the question on the scoring system. So we didn't ask the board members to score applications. They provided feedback. If they really thought something wasn't going to go, we took that very seriously. But otherwise, no, nothing to add. Thank you.
Perfect. Thank you so much to University of Missouri. Our next presentation is from the University of Texas Medical Branch. I'm going to hand over the quote-unquote microphone to Monique Papadis and John Cook.
Hello and good afternoon.
Good afternoon, and thank you so much.
Well, I'll go ahead first as told by my university partner because my name is the first one on this board. Production John Cooks with the Galveston Island Community Research Advisory Committee.
And I'm Monique Papadis. I'm an assistant professor in the Division of Rehabilitation Sciences at the University of Texas Medical Branch in Galveston. And I'm also one of the investigators of the Patient-Centered Outcomes Research Grant on the Elderly.
And greetings from the birthplace of Juneteenth, Galveston Island. All right, we had to get that in there.
Yes, we did. So we're actually in Galveston. So there's, we don't have our normal events that we normally plan every year with the march, but there are tons of events that are happening online virtually. So just an overview of our presentation. We'll just talk about our partnerships and dissemination efforts, as well as some lessons learned with regards to dissemination practices, and get the perspective from Mr. Cooks on the community partner perspective. And then just talk about the development and continued partnerships that we've developed over the years through the R24 grant and working with the Get Cracked community. So this is a really nice figure that was developed by the investigators and faculty members of our university's Institute for Translational Sciences, Dr. Petronella Croissant and Dr. John Prohaska, who both are patient-centered outcomes research members of our team. And so it just really highlights how the university has really focused over the last few years on stakeholder engagement, both with patients and with community members, and also organizations within our community. And we incorporated in throughout the entire process or the different types of research when you think of translational research. So from all the way from the basic research moment all the way to public health in the community and population level work. And so with that, there's in each of those different areas, there's different types of as you can see, the kind of blockouts, there's different ways that we engage the community and also with demonstrating the usefulness of the research, developing new approaches, and with regards to today's topic, the dissemination of our findings. So part of our center that was the patient-centered outcomes on research on in the elderly, we had three main projects. The first one was on looking at mammography screening in older women. And so for this project, we developed partnerships, mostly were with the clinical and university partnerships with UT MD Anderson Cancer Center, as well as Oregon Institute for Patient-Centered Research and also their practice center at the Oregon Health Science University. And so with this, we were able to develop a partnership with the community for not only with dissemination, but also they were very instrumental in the recruitment phase at the Houston Food Bank. One of the coordinators actually contacted someone at the Houston Food Bank because we had a challenging time trying to identify and getting the perspectives of older Hispanics in the Houston Galveston area, and connected with the Houston Food Bank. And every Saturday, just lines wrapped around the building. And so the partnership was developed. They even created an office in there for our staff to be able to engage with the community. And so there was our second project that we had was related to stroke rehabilitation, specifically inpatient rehabilitation, as well as skilled nursing facilities. And so we built partnerships with the St. Vincent's House, which is a nonprofit organization in Galveston that does a lot of work within the community, providing free to low-cost healthcare services. And so we built a partnership with them to be able to identify key stakeholders who may not otherwise be involved in research. And then also, since the project was focused on stroke, we built partnerships with local and local stroke support groups, where we also worked with them with sharing our results, presenting to them, getting their feedback, and also them really helping us guide our future work. And then we also build partnerships with two facilities where individuals are less mobile. The Housing Authority, specifically Holland's House, which is a low-income facility, and where individuals may not have transportation. And so we built partnerships with them as well as the Meridian, and they would regularly invite us to present our findings, interview residents, regarding their thoughts on our work, and providing suggestions and feedback for dissemination, as well as, again, future work. And then John, I'll explain project 3.
The third project was where our organization had its greatest input and engagement with the bioethics dialogues around PCOR and SER. And I think everyone is familiar with the abbreviation, so we won't spell that out. And basically what it consisted of were dialogues centered around basically 3 questions. One relative to the role of PCOR and SER in guiding health policy in the U.S. Secondly, the function in the physician-patient relationship, and then also how commercial interests should play, if any part, what part, if any part, in determining PCOR and SER policy. It was a session over the course of about 7 weeks, where health literature was provided to the participants beforehand. They read it, came back with the suggestions, just had a wonderful discussion, and came out with their final set of important outcomes around those particular questions and the things that really resonated with them, and posited some very strong conclusions relative to what that actually looks like.
Oh, just regarding our community dissemination efforts. So this is just some of the kind of key areas where we chose to disseminate many of our findings from our work through the PCOR grant. And the location of the university is very central and easy for community members to gain access to. And so many of our events and seminars that we would have on campus, we would have great attendance from community members to be able to, ask questions and provide feedback. We also partnered with the Galveston Aging Care Network, where we presented many of our findings. And so the population or the stakeholders there are mainly leaders within different healthcare systems around the area, community-based, where they provide community-based services. And so a lot of the information was shared with them as well, so that that information can also be disseminated to their partners and residents. And then as many universities and other R24 centers, we have luncheons. We always go into the community to present our findings, as I mentioned previously before, especially with the living facility. We've developed great partnerships with them, and so they regularly invite us to come and during the residents' social time, where they can come and all gather and hear about the latest, greatest findings from our work. And then we also have stakeholder advisory boards that we have developed for the grant, but also each project regularly develops stakeholder advisory boards that includes members of the community where the research is being conducted, as well as including even national partners as well, and community organizations. We've developed community-driven reports, which is in relation to what Mr. Cooks mentioned, and then also press releases, editorials to make sure that information is disseminated, as well as newsletters are regularly sent out to the community, and also on websites and social media. Just recently, over the past few years, our center has really been focused on increasing the dissemination efforts on social media and website. And we are aware that that's a unique or population. However, there are many, many older adults in the community that's also on Facebook and Twitter now. So here's one example of a university really driven dissemination effort where we call the Sci Cafe, where science and communities interact. And so this is actually in a local coffee house that's really well known on the island. And so here is where it's very informal, as you could see, and researchers and scientists come and present their findings to the community. And this gives the community a lot of opportunity to ask, one-on-one questions with researchers on very important topics that are affecting the community.
Well, just before we move on to that one, we're pulling this together, and I was talking with Monique, and she had pulled up the picture. I asked her, "What's wrong with that picture?" And what I was alluding to in that, basically for this particular picture, my question would be, where's the African American community in terms of this interaction? But I say that to say, as we work on the dissemination, that we've got to make sure that, not to say that it is exclusive, but because of, for whatever reason, that any African Americans are not there, but we have to make sure that we are doing everything that we can to include the populations of color in these disseminations and interactions.
So here's some of our lessons learned, really engaging early, disseminate early, as others have mentioned. Don't wait to the very end of the project to disseminate your findings. Include stakeholders from the very beginning with determining the best ways to disseminate the information and how to best disseminate that information and who you give it to, and how they can also help with keeping the cycle going with disseminating the information that they learn. And also, because our center was focused on older adults, a lot of the information was targeted towards older adults. And so a lot of the feedback that we received through direct interviews with stakeholders is to make sure that we have disseminate the information and also target younger adults who are not older adults yet, because they thought that, you know, if they receive if those individuals, their children receive the information early, that they can also prepare for older at the time when they become older adults as well. And then also, yeah, making sure you include the community partners in the creation of manuscripts. This is pretty a new area for us that we really liked when we heard about the other centers at the last R13 conference that include the partners in the actual development of manuscripts and writing of sole authors of manuscripts. And so we've started developing that as well. And I contributed to a special issue where we had, survivors of brain injury also contribute to the dissemination and development of the special issue. And then also one key thing that we learned from Project One, which was on the mammography screening of older women, is really consider how you frame the messages in the dissemination projects. The information of sharing of the results that we had related to over-detection or over-screening of breast cancer, they thought that we were trying to sway them to not get screened. And so, but that was not the intent. So you just have to be very careful, especially when you're describing risk to older adults or any population really. Just be key and on how the information and the messages are framed. And then lastly, all projects should have some form of mechanism to be able to assess your impact and reach. It's not, okay, you create a product, how do you know that they're using the product? How do you know that once someone receives the information that you're providing, do they share that with others? And just having a mechanism to be able to keep that going on so that you can increase your reach of the information that you want to share with the community.
Perfect. I just want to give you an announcement that you are you are at the end of your 15 minutes.
Oh.
It's the question and answer period.
Uh-oh.
Okay, just throw this in right quickly. Coming from a premise in terms of the community department, starting with the end in beginning with the end in mind, and also just like evaluation is built into any research, dissemination has to go right along with it. You can't have one without the other. Pulling on the things where, of course, there's community inclusion in the whole research process. It allows for that buy-in and then for them to be able to talk about it, because word of mouth is your best advertisement. And so it just puts the community in a place that they know they have buy-in, they're able to sell it, if you will, if it need be sold. And then think about the results, how you get the results out there beyond just a form, beyond a pamphlet, so that the community is really met where they are and you're able to give them this information, and with that, get them totally on board, because we know, as our previous presenter stated, the more community input that you have, the richer, the better the research. So that's going to be true to the devisement of it, as well as the dissemination being built all the way in, being kept totally in the loop. Next slide, or we can slide on. So we're still looking at developing things, even though the best practice and the mindset there, you have to talk. And pulling together this presentation, it hit me that with Monique and I, Dr. Papadis and I, walking and talking through this, that we missed that on the particular project I was on, we missed an opportunity for some community dissemination. So we're going to go back and fix that. But it's just those kinds of things that have to take place in order for you to really have the partnership as well as get the word out there. Next and last. Okay, you just
Yeah. So we just in summary, we, because of working with John Cooks, we've developed a continued partnership with his organization to continue to not only with information sharing, development of stakeholder groups, making sure that we reach the African American community, but really just building a capacity and infrastructure where it's just this continuous partnership for lifelong, right?
Yeah, I did the community better than your family.
Yes. Okay. So just give an acknowledgement. Thank you.
Okay, sorry about that. Thank you so much. I was like, wasn't very sure where to click. But I want to make sure that we get to some questions. The first being from Usman Khan. Can you share an example of community-driven report? Is it a paper document, digital? How do community members contribute to them?
Okay, so I'll just briefly say it and then I'll let John, because John was actually one of the authors of the report. So, for the bioethics dialogue project, where they had regular discussions about patient-centered outcomes research and comparative effectiveness research, through those discussions, the results of, what things are most important, what should be considered related to patient-centered outcomes research. And so the note taker basically took all of that information from, the transcripts and that conversation and put it all together. And then each member, so each of these community members contributed to the development of an actual report that highlights, what they found, what's important to their community, and how to move patient-centered outcomes research, further.
So in addition to also co-authoring the report, as Dr. Pompous was just saying, from putting the findings back together, the community members have to go back, rank them, prioritize them, and then actually make a statement relative to the experience. And that was, of course, included in that. So that even goes back to an earlier person's question relative to those stories and that voice and whatnot. So we try to, and I'm a major proponent for that we always capture the voice, the true voice in that. And so that as a part of that report, we made sure that was included.
Perfect. Thank you so much. From Hey Han, we have another question. So Dr. Pompous and Mr. John, thank you for sharing your wisdom and knowledge. One, how early do you start disseminating, and what do you disseminate in the early phase of research? And two, what were your impact indicators on how were they measured?
Well, I'm a proponent that you, as I said, you start with the end in mind, because usually the last thing you do is disseminate, but no, you start at the very beginning. So it always, because ideally, for the way that we function in terms of my organization, we're a part of that from the onset. So you're keeping people in the loop totally. Again, you early, you do not necessarily have any findings, but you're talking about the process of building a grant, where the grant is at that point. Has it been reviewed? Do we need to revise it? And you keep the community built in all stages of it. So it starts at the very beginning. It's not just, again, it's a comma, not a period.
Yeah.
And I'm sorry, what was the second part of the question?
What were the impact indicators about, I guess, measuring the impact of the dissemination efforts? So that piece is a little tough, and so that's why it was part of the lessons learned. With manuscripts, right, you could measure the impact. You can see how often it's been downloaded, shared. When it comes to developing manuals, booklets, things of that, print materials, that one's a little bit harder to see what the impact is. So there's just, I mean, I guess it really depends on what you're doing.
And then also for the mechanism whereby the community actually takes in the information better, because they may not be in, let's be real, there could be literacy issues, access to that actual literature, if you're not maybe on a subscription list and that kind of thing. So you have to create the opportunities whereby you're at least saying it, if that is the way that it best gets out. So that's a part of that building in and having that touch in the community. How do we best give the message? Because everything is not going to be written, everything is not going to necessarily be auditory, because some people, for the different learning styles and how they analyze information, you just have to go at it from all angles, really, and determine what's best for that target audience, and then even beyond the target audience, pardon me, the general population.
Perfect. Thank you so much from University of Texas Medical Branch.
Okay.
It says, remind everyone that if your questions have not been answered, we will be combining them and sharing them to our panels for them to distribute later at a later time. I now want to offer closing remarks and reflections for our day. We'll start with our funding agency, Agency for Healthcare and Research and Quality, and Harry Kwon to offer his closing remarks.
Thank you very much, Diamond. And first and foremost, I want to thank all of the presenters today for sharing your experiences, perspectives, and lessons learned. It was great to see, even through these presentations, how partnership is modeled with patients and community advocates and researchers and working together to deliver these great presentations. I just wanted to take a brief moment to share some of my reflections from the wonderful presentations. First, I mean, there are a number of factors that are involved as part of capacity building in patient-centered research. We heard about the importance of support from the institutions, the various approaches taken to build capacity, and the essential resources that are helpful and critical needed to carry this out. Straight from the beginning, thank you very much, Gail, for sharing your journey. I thought it was so important for all of us to hear how you got involved and sharing your perspectives and your experience. Also, sharing the LBD approach, which is to listen, bridge, and deliver. So listen with bidirectional learning with patients and community, the patients in the community and researchers, providing a bridge through leveraging these resources and delivering through sharing of these resources. Whenever we ask questions, we need patient advisors to help us think this through. I mean, there's a lot of things to go through, and we just need the core element here is the need for patient advisors to help think research questions through. We need the help from the patients to help researchers frame the right research questions. That was a point well taken from the get-go. Gail also shared the impact of having campus-wide support for this effort here, and the need for organizational support was also echoed by Denver Health. And it's great to hear about the executive level support that they received as part of their program. The opportunity to develop skills of the advisory group members through education is another key area. The community advisory panels, as you heard, serves as a bridge with the community and research. So that's a very critical link that's there. We also learned about essential resources from Indiana, the importance of community outreach, such as health fairs, along with a peer education program, and also building broad partnerships. And we've also learned about the fruits of such patient and community engagement and the impact on research, such as improving data collection methods, refining education materials. As you just heard, Missouri just shared the wonderful work about their patient advisory board as another example. And this provides significance from the patient perspective, recruitment ideas, a review of materials, and so forth. The contributions from the patient advisory boards are vast when it comes to all elements of research. It was especially important to hear the feedback from the community and patient advisors on what it meant to be on these panels. I thought this was very fascinating to hear. Some of the ones that I recorded here, like having the opportunity to contribute, to do something good, feeling valued and appreciated, being part of a team, always allows a better understanding of the research. And these participants always recommend being part of this particular advisory group or patient advisory group. It allows members to grow personally and professionally. And of course, my favorite is, I think I've heard this through several presentations about the food aspect, being fed. I thought that was very interesting, and I certainly could relate to that. Just want to thank everyone for sharing the ingredients of capacity building and laying out the importance of organizational support. It was also very helpful to learn about some of the models and examples being used to implement partnerships in patient-centered outcomes research, such as the flexible model of engagement shared by Henry Ford, and the food medicine program sharing an example of culinary medicine education as discussed by the UT Southwestern team. The flexible model supports many types of patient engagement, which indicates that engagement can be viewed not just one way or a method, but multiple ways and roles. One of the keys of the food and medicine program is talking with members of the community regarding nutritional education to understand the unique aspects and perspectives of food access and nutrition. These examples shared reinforces the importance of partnerships and how they play a key role in implementing and conducting patient-centered outcomes research. Many thanks to the UTMB for sharing examples of disseminating and connecting with the community. For that one example, we just heard about the Science Cafe and sharing lessons learned, especially to engage early and disseminate early. I think that's a wonderful takeaway for everyone to know, and to include stakeholders on how to best disseminate the information. And in addition, thank you for sharing the community partners' perspective on best practices to get the community on board. There is a need to continue the dialogue with everyone, and that will continue to build partnerships, and those partnerships will be built stronger and stronger. I just wanted to conclude that the best practices and lessons learned shared today provides, to me, I look at the wind behind the sails to integrate PCOR in health systems and research with the aim to improve quality of care and outcomes for patients. It is important to recognize the crucial role that patients and community members, including advocates and advisors, play in working together with researchers and others to improve how things are done, what matters to the patient, and ultimately improving outcomes, which we all want to achieve. Thank you again, and I'll return it back to Diamond.
Thank you so much, Harry, for giving those closing remarks and reflections. I will now hand it over to Daniel Mullins from the University of Maryland, Baltimore.
Thanks. So certainly Dr. Kwan did a great job explaining the significance of the presentations today. So I would like to begin by reflecting a little bit. It was more than 6 years ago that the R24 was awarded from AHRQ to the University of Maryland, Baltimore. There were 2 of us who were awarded these R24s, and today you've heard from all 7 who eventually received these R24 grants from AHRQ. So I'm sure that the PIs of the other 6 R24s would like to thank the Agency for Healthcare Research and Quality for providing us with funding to build the awesome partnerships that were described today. I also want to thank ARC for making available not just the opportunity for us individually to learn from our patient partners and our community partners, but also for setting up monthly calls. Harry himself participated in many of those monthly calls in which we were able to learn on a monthly basis what the other R24s were doing so that we could improve what we were doing by learning from each other. And so a few years ago, we thought it was appropriate that since we had learned so much from our patient and community partners, and we had learned so much across these 7 R24s, that we wanted to share it with other institutions so that they too could build the capacity to do patient-centered outcomes research. And So once again, we went back to ARC and we put in an R13 proposal, which is a conference grant proposal. And we proposed to take all 7 AHRQ-funded R24s and have them present. Some of you participated in last year's in-person event, and we thank all of you who are participating virtually today. So I'm very grateful to ARC and very grateful to the patients and the PIs of the other R24s who continue to teach me as we learn together. We have heard a lot about listening to the voices of patients and community members and how we can partner more authentically. And only with those authentic partnerships can we truly transform research to be more patient-centered. I started today by acknowledging the fact that this day was deliberately chosen as we were planning for this year's event, and we chose Juneteenth. I hope that today on Juneteenth that we haven't just discussed how we can improve patient-centered research, but that we also think about the broader missions that all of our institutions have, which is to improve healthcare decision-making, which is to promote health equity, which is to address those social determinants of health that would allow us to not only increase health equity, but social justice more generally. And so I am very grateful to all who presented today, our patient and community partners, as well as our researchers. I also wanted to give a special shout out to the Patients Program staff who helped today to make things possible. And in particular, I would like to thank our host for the day, Diamond Hale, and I will turn it back to her now to close us out.
Thank you so much. Thank you again for your attendance today. Without you, research is not possible, and I want to acknowledge all the attendees that are on the call, especially for your questions, for you taking your time today on a Friday to lend your voice in your ears to really make sure that we're building a different way of doing research that really does include all communities, all cultures, all participants, that really change the narrative of how we do research. I want to say a special thank you to our panelists, including those from each of the 7 institutions, and also our community members and patients that really gave their time today for participating and giving their knowledge that they've learned throughout their time together. I would like to also thank the School of Pharmacy's IT department, who have literally made this possible and helped in the technological field that some of us are not really equipped to manage. I really do want to appreciate and thank all of those that helped in the background and in the behind the scenes to build this amazing day-long conference that has not really been faltered but changed just slightly due to the nature of COVID-19 and being able to pivot and still be able to deliver such amazing information for all those involved. I would like to thank our sponsor one more time, the Agency for Healthcare and Research Quality, the grant that originally gave us the foundation to be able to build this conference together. The contents that were displayed today are not the official views of ARC, but of the individual presenters and or institutions. All these presentations and the recording of our day together will be posted on the Patients Program Facebook, website, and YouTube. We will announce that information post-event. I would like to, again, thank you all for your participation. Words have escaped me today. Participation and presentations today. A post-event survey will be emailed out later today to all attendees. Please submit, and you'll also have another chance to win a raffle. We do have a couple raffle winners today that have given us their emails that we will be contacting. If at any point you do have any questions, please feel free to contact us at the patients@rx.umaryland.edu, and please visit us on our Facebook, our website, and our YouTube channel to get more information from today. Again, thank you so much for allowing us to make this possible.